Okay, so I'll just start off by saying thanks for inviting me to share my Bevan project with you today. I'd like to start the presentation, if that's okay, with introducing you to my new member of staff, and she's called Mavis. I'd really like to explain to you what Mavis is and how she came to becoming a member of the team. And to do that, I really have to take you back a step, probably. So a few years ago, Valindra NHS Trust had experience of using the world's first virtual assistant in oncology. And after seeing the success and benefits to patients of this assistant, I really hope to trial it in a different healthcare setting to see if we could replicate that success. And that's really where my Bevan application came in. So what is Mavis, you're probably asking? Mavis stands for Medicines Advice via Information Systems. So Mavis is a virtual AI assistant, and we sort of commonly call them chatbots, but that really is underestimating the capability of the AI assistant. Mavis uses an IBM Watson platform, and the idea behind it is that she provides very quick and consistent answers to frequently asked questions. She's got a real conversational tone to the language that's used within her, and the plan is that she can continually evolve and learn through user feedback. She is currently available in Welsh and English language, and we are trying to pursue whether, if we broadened it, we could have other language translation capabilities within that. There are now a couple of chatbots in preparation and have been deployed, and those are called Kerry, Rita, Maisie, and you might well be familiar with one or all of those, and there are several others in development. So why did I think that something like this would be useful? And I think it comes back to the whole premise about good quality information and conversations that we have with patients about their health. And most of us would agree that those are key, but those conversations are often conducted in very time-limited and stressful clinical environments where both the time and the space constraints do not really allow for quality conversations to happen. And what we thought was that through using artificial intelligence, through this machine learning and using natural language processing, it was actually designed to allow patients to have timely access to this information through conversations, anytime, any place, anywhere, helping them to make better choices as they live with their diagnosis. And why porphyria, you're probably thinking. Cardiff and Vale UHB hosts a UK-wide advisory service for patients with porphyria. We offer specialist advice regarding the safe choice of medicines in this condition. And some of you may not have heard of it. It's a rare genetic condition and affects approximately 1 in 75,000 individuals. So in the UK, we estimate that's probably around about 500 or 600 patients that we know are diagnosed with the condition. They often experience acute attacks, and that can be triggered by exposure to commonly prescribed drugs, which is where we come in. Because of the rarity of the condition, the average practitioner might never come across a patient with porphyria, meaning that expertise in this area is generally limited to a few who have developed an expertise in this subject. Just going to move on. So I suppose what I'm saying to you is that the average porphyria patient will live their life without, hopefully, any problems and without any episodes of acute care with their porphyria. So they generally tend to manage their condition, self-manage their condition very well by the avoidance of triggers, and that includes a careful avoidance of unsafe medicines. What we discovered was that of those 500 or 600 patients that we know about within the UK, not all of those are calling us for advice by any stretch. And so we wondered, where are they going for their advice? And that led us to believe that perhaps there was a level of inconsistency with that advice that they might be receiving. So we asked that question. And you can see this on the next slide. So worryingly, more than 50% of the patients get their information either from a non-specialist, friends and family, Facebook, other internet sites. And we asked them, how does it make them feel if they have to wait for information? And as you can see, many of them say they feel anxious and frustrated, helpless. It affects their sleep and affects their concentration. So accessibility of information we thought was key in order to be able to improve the outcomes of these patients. So Mavis was developed using unstructured feedback from a stakeholder group in the form of a focus group. And we wanted to allow patients or carers to have the maximum input over the development of Mavis and to identify the priority areas for us to work on. Next, we come on to how we went about doing that. So working very closely with an external partner who had had previous experience in this area, we identified some frequently asked questions within the focus group, as I've mentioned, and we identified 20 frequently asked questions that we thought we could pursue in Mavis, and they're called intents. And you'll realise as we probably go through that language was one of the main challenges, I think, for me, in terms of understanding the language that the developers would use that I had had no previous knowledge of. So at the start of last year, spring of last year, the external partners managed to code 9 of the intents into Mavis before, unfortunately, getting pulled into another COVID-related project. Rob mentioned how COVID had impacted on all of the projects, and I'm not alone in that. But we were managed to trial those 9 questions amongst a patient user group, which was the intention all along. And you'll see on the slide that there was very much a process to it. So we wrote the intents, we collaborated, we tested the prototype. There were further adjustments and developments made to Mavis. Then we went out to a slightly wider patient testing group. Then it came back again for further developments. You see the kind of pattern behind this. And you might wonder why it takes so long. Well, because of the complexity of the natural language used within Mavis, the questions have to be phrased in a number of different ways to mimic the natural language and the natural questioning technique the patients use when they're speaking. Mavis also had to be trained to understand and identify several versions of the same word. For example, some people say jab, some say vaccine, some say inoculation, and patient language and healthcare professional language can sometimes be very different. So unfortunately, due to the time and financial constraints, we were unable to get the 20 questions coded, but we were able to work on several of the more complicated aspects. And one of those, I'm pleased to say that we managed to really get finalized, was a question around hormonal contraception. So going swiftly on without running out of time to the patient survey, 54% of them like the idea of using a chatbot, and 69% of the patients that we questioned had used a chatbot previously in non-healthcare related situations. And hopefully you can read that slide. It's a bit small to see, but those are the aspects of using a chatbot or a virtual assistant that they like. And I guess for me, it's around accessibility, the fact that they would have an instant response, that they thought it might be reliable. And those were the key aspects of why we decided we would develop a chatbot. Concerns that they might have, understandably, I suppose, when you think that it's patients that we're asking, is that obviously they might get the wrong information. A lot of individuals said they prefer talking to a person, and I think that's absolutely right, that we have a triage system built into Mavis, so that if the outcome is not something that they would expect to have, or that they have further questions, that they then are able to speak to a person as an option for their care. We also questioned staff here and clinicians across the UK who potentially might come across these patients. And interestingly, a quarter of them say that they really have enough time to answer all the questions that are asked of them by patients. 61% like the idea of a chatbot, and similar themes here. Look, that it would be available 24/7, that it would give patients an instant response. They were thinking of us when they said it might free up some of our time, which is which is right down the line, and it's a resource that family and friends could also use. And then concerns that they would have are very, very similar. You can see the theme that it may give out the wrong information, it might give out outdated information, that it may not be relevant. A lot of people in the sort of narrative said that they might worry that porphyria questions might be too complex for a chatbot. So obviously we'll take all of that into consideration. I just wanted to share with you then some of the quotes that we managed to retrieve from the focus groups and the surveys that we used, and it looks to be a very, very valuable resource. I like the following few because public are increasingly getting used to this type of conversation with non-healthcare companies, and that healthcare should catch up with this technology. I like the fact that it's better than patients accessing unverified information on the internet. And then the last one, absolutely, we would treat Mavis as a part of the team. She would be supervised as such, she would be trained as such, and obviously wouldn't be dealing with questions that was beyond her capabilities. So challenge that I've faced, I've mentioned the COVID pandemic. I think that for all of us meant that we had to do things differently, and face-to-face focus groups weren't possible. We had to do all of that virtually. My external partners were pulled in a number of different directions and then had to leave the country because they were American based. I found that there was a lot of skepticism about the use of this technology, fueled probably by some of the negative press around it in terms of the accuracy and the quality of information, and some issues around the governance, intellectual property issues. I've already mentioned language to you. I mean, I had no idea when they were talking about UIs, that they were talking about the user interface and how that looked to the patients who are using it. I would say that partnering with an external organization presented challenges in terms of, you know, trying to stick to deadlines and trying to make availability at times that were convenient to both of us. I was surprised that there was a very limited experience of using this kind of technology still within the NHS, and there was no strategy that I could see for the use of it, and I felt like sometimes there was no appetite for it. Next steps though, having work closely with the British Porphyria Association around the development of Mavis. They are really, really keen and see an absolute market for using Mavis in that group of patients. And so we're going to apply for a grant, the Artificial Intelligence in Health and Care Awards, to try and take forward a bigger rollout and a better evaluation of using this technology. But similarly, personally, I'm really keen to look for opportunities to use it in other parts of the organisation and within the NHS for other disease states. We chose Mavis to be used in porphyria to try and prove that concept. I believe we've done that, and so I'm really excited to be able to share that, hopefully, with other users and other individuals who are hoping to take forward something along the same lines as this. And then really just lastly, I'd like to thank my partners. I had a lot of support from Bevan, obviously, but also from Philip Webb, who was the original individual behind Rita, the virtual assistant in Velindre, and within Cardiff and Vale, the innovation team too. So thanks to all of them.